All right. Do not resuscitate orders. This is another, messy situation that comes up some. And I feel like what happens is we get called into these scenarios. And then the question is, okay, what do we do now? All right. So I want to talk about do not resuscitate orders. So let's imagine a little scenario, something that may happen in real life. Okay. So let's say you're called for a 90-year-old female. This patient's at a nursing home. They're found by caregivers in cardiac arrest, and you get there, and the patient has a DNR CCA paperwork. Okay, a DNR CCA paperwork is signed at the bedside. Okay, what do we do now? Okay, now probably most of you already know what you're going to do in that scenario, but stay with me. Let's just think about this for a second. Okay, so there are really two different types of DNR orders in the state of Ohio. One of them is called a DNR CCA, and the other one is called DNR CC. This is extremely confusing terminology, okay? And the thing is, they're really actually fairly different. Even though they're only one little letter apart, they actually say very different things, okay? A DNR CCA, okay, this means that, if the patient goes into cardiac arrest, then, we are not going to resuscitate that person. Okay, what that means is that really the DNR CCA doesn't mean anything until the patient actually goes into cardiac arrest. The moment before cardiac arrest, that DNR CCA has no bearing whatsoever on the medical care we should provide. Okay, only when the patient goes into arrest does it then become active, so to speak, and tells us we are not going to resuscitate this patient after they have gone into cardiac arrest. This is very different from a DNR CC. That's basically active immediately. As soon as you sign, or the patient or caregivers or whatever signs a DNR CC, that's basically saying we're only going to do comfort care measures for this patient. That's the one where not only are we not going to do CPR and stuff like that if they were to go into cardiac arrest, but likely we're not going to do a bunch of other things. We're going to do, we're going to focus on comfort. We're going to focus on symptom control. We're going to focus on controlling nausea and pain and, reduce suffering. But we're not going to necessarily focus on really aggressive care, okay? So if you roll up on scene and somebody is, say, just in respiratory distress, and they have a DNR CCA, well, that DNR CCA doesn't mean anything right now. They still have a heartbeat, right? So you need to do everything for that patient. If, in the process of you doing everything, the patient then goes into cardiac arrest, you are then supposed to stop and do nothing. I'm sure many of you are thinking that seems really weird, and it is kind of weird, but that's in theory what the DNR CCA means, okay? Whereas, if we roll up on that patient who's having respiratory distress and they have a DNR CC on their chart, okay, that means it's just comfort care, and then how much we are or are not supposed to do becomes, a little bit messy, and we're going to talk about that in a second, okay? So I hope that makes sense. They're not the same thing. They're very different. So if we go back to my scenario that I brought up at the beginning of the DNR section here, I said, okay, 90-year-old lady called by a nursing home. We get there. The patient's in cardiac arrest. There's a DNR CCA paperwork there. What does that mean? Right? They are now in cardiac arrest, so it means we do nothing, okay, and we're done, basically. We can stop, essentially. All right. When you get that DNR paperwork, though, obviously we still want to assess a little bit about that paperwork. Let's make sure that everything looks to be in order, okay? So we're going to confirm on the paperwork the patient's name, it's the right patient. We don't have some other patient's chart or something like that, right? Make sure that all the dates seem to make sense, okay? There may or may not be expiration dates or something. Just make sure all the dates seem to make sense. And then there should be some sort of valid signature, from a physician or from the patient or the caregivers or something like that, right? You're not lawyers. I'm not expecting you to be lawyers, but just make sure everything seems to be in order. And if so, then you can go ahead and honor that DNR paperwork. When in doubt, if you just don't know, or you're like, I don't know what the heck to do with this. Is this right? Is this not right? Right? When in doubt, just call medical control, right? you can call University Hospital, you can call any of the hospitals, where there's medical control, talk to the physician, get their opinion on things. That's totally fine. But so long as that paperwork looks in order, then you can go ahead and do what it says, okay? Now, as always, tricky situations, lots of messy scenarios when it comes to DNR orders, and so, I want to talk about these, okay? If you get called, let's go back to that scenario. 90-year-old lady, you get called for cardiac arrest, you get there, the patient's in cardiac arrest, there's a DNR CCA paperwork, okay? What would be a reasonable question to ask is, why did we even get called then? What are we doing here? Why was 911 even called? Okay. Now, sometimes it's just because somebody panicked, somebody didn't know what to do, somebody was scared. And what do you do when you're scared? You call 911. And that's reasonable, right? And we should be forgiving of those scenarios. But be careful. Maybe there's something weird. Maybe that paperwork's old. Maybe that paperwork was rescinded. Maybe, something's different. Maybe the family changed their mind, which happens sometimes, okay? So that would be my first question when I get there in that scenario, 90-year-old cardiac arrest, DNR CCA paperwork. Why did we get called? Make sure there isn't some reason there why we got called that all of a sudden changes the game, and now we really do need to, do everything, okay? So that would be an important thing, all right? The next tricky situation is I have it as, where did I put that form again? So let's say we get there and, again, maybe somebody was panicked, but now we're there, and then somebody more, maybe the charge nurse comes in, say, and says, no, that patient has a DNR order. Where did I put their form? Something like that. That's the scenario I'm imagining, okay? That's difficult. That puts us in a weird situation. What are we supposed to do? Okay? The protocol says that if you have every reason to believe that this is, you're going to be handed a valid DNR order, okay, you don't have to start resuscitating the patient, okay? You can wait, get the paperwork, confirm, okay, yes, they have a valid DNR, and that's okay. You don't have to do some pseudo CPR while we're getting the paperwork or something like that. Again, so long as you think everything is going to be reasonable. If your spidey sense is going off though, and you think something's weird, and they're not going to come up with this paperwork right, then obviously just start resuscitating the patient. But that is okay. All right. What about oops, the patient has a DNR, okay? This also happens sometimes, right? We get there, boom, we're not told anything, we bust in the door, patient's in cardiac arrest, and we do our thing, right? And, and that's fantastic. We get there, we're doing high quality CPR, we're doing all the things we're supposed to be doing, and then finally somebody comes in and says, wait, they have a DNR. Oops, right? What are we supposed to do then, okay? Again, the protocol is clear. You can go ahead and stop. If you started doing a resuscitation, but now you have been presented with valid DNR paperwork, you can go ahead and stop at that point. Now, what gets even messier is what if you started, you got a pulse back, and now you are presented with DNR CCA paperwork. This happens, okay? Well, now go back again to what a DNR CCA says. Remember, the DNR CCA isn't really active unless the patient's in cardiac arrest. I realize they were in cardiac arrest, but now they are not. They are not in cardiac arrest anymore. So unless the family is telling you something different, you should start treating that patient because, again, the DNR CCA is only active if they're in cardiac arrest. They're not in cardiac arrest because we got a pulse back. Yay. Okay. You got to treat and transport that patient. Again, unless the family gives you different, whatever. But that's a different scenario. That's even more messy, okay? And this happens, right? I mean, this happens all the time where, again, somebody, EMS gets called. EMS does a great job. They get the pulse back. They bring the patient to the emergency department. Now they're with me. An hour into their emergency department stay, all of a sudden the family comes in and says they had a DNR order. Well, okay, right? What do I do at that point? Well, I say, well, they have a pulse right now, so, we're going to keep going so that DNR that DNR-CCA isn't valid right now, okay? So I hope that makes sense. That one's confusing, okay? Keep in mind that, again, these DNRs, my next one's the dying words, this would be, you're like, the patient's like keeling over and is like, they had a DNR-CCA and then all of a sudden they're like, don't let me die, and then they go into cardiac arrest, what do you do then? Again, these things can be rescinded, right? A DNR paperwork isn't for all time. The patient, the family, whoever can say, no, I don't want to do that anymore. We don't want to follow that DNR paperwork anymore, okay? Again, these are messy situations. These are difficult situations. There's probably no great answer, but I would say you should resuscitate that patient, okay? When in doubt, I would provide medical care, right? Not when in doubt, don't withhold medical care. When in doubt, just provide medical care. I think that's the safer choice, okay? So that can happen, very messy. How about, again, we talked about this patient who was in respiratory failure, who's having difficulty breathing, okay? This is probably the thing that's most tricky, because what happens, this is the scenario that happens. Somebody has a DNR CCA, okay, which again, what that document says is if the patient is in cardiac arrest, don't do anything. But now we have a patient who's critically ill, who is looking like they're going to progress to cardiac arrest if we don't do anything, okay? But, as I've already said, that DNR is not in effect yet if it's a DNR CCA, because they are not in cardiac arrest. What are we supposed to do, okay? In some states, not Ohio, they have other forms that are called like POLST forms or MOLST forms, okay? And those actually specify a lot of these questions that we really want the answer to. They say things like, do you want to be intubated? Do you want mechanical ventilation? Would you want vasopressors? Would you want antibiotics? Okay, would you want chest compressions, et cetera, et cetera, et cetera, right? It actually spells it out very clearly. That would give us much more clear direction. But unfortunately, we don't have that in Ohio. So when you're presented with these difficult situations of they have DNR CCA paperwork, it's valid, but they're not in cardiac arrest yet, but they look really bad, what am I or am I not supposed to do? Okay, again, the strict letter of the paperwork would say you do everything until the patient goes into cardiac arrest. However, you can still talk to the family, right? Because the family, who probably has capacity, which you will assess, right? So long as the family has capacity, they can continue to make medical decisions for the patient. So if the family says, well, no, like dad would never want to be intubated, whatever, something like that. Okay, well, that's fine. Then you can go ahead and honor that. But you got to start asking real specific questions about what the family thinks the patient would or would not want. And if they, don't want you to do this, don't want you to do that, don't want you to do that, that's fine. Document, right? And then we can go ahead and withhold those things. But just keep in mind, it is not the DNR CCA paperwork that is telling you not to do anything, because the DNR CC paperwork is saying do everything until they are in cardiac arrest. That's the family that's telling you to hold off, okay? I realize that sounds like a subtle nuance, but this is a really important difference, and sometimes people get this confused. All right, and last but not least, pregnancy, you come back again as an exception. And apparently I'm not a legal scholar, but the protocol makes mention of the fact that I guess DNR orders, you're not allowed to do that if the patient is pregnant, because again, of the unborn fetus. And so in theory, there should be no DNR order on a pregnant patient, like it shouldn't have even been signed. But I would be very cautious about anything surrounding pregnancy and DNR orders. That would definitely be a time to call medical control and start clarifying. So pregnancy, as you've seen, is like always the exception, okay? All right, last but not least, hopefully you're still with me, last slide here, is a very specific protocol that's often referred to as the Diabetic Treat and Release Protocol. And this is a very unique protocol in some respects, because it's really the only protocol where we're actually saying when you can treat someone and then just be like, okay, you're okay now, you can go. And it's not a termination of resuscitation, where we've actually protocolized when we can let the patient go, okay? And so let's imagine a scenario. Let's say you're called by the wife of a patient for a 50-year-old man. He has a history of diabetes, and the call is for altered mental status, okay? Not surprising. We get calls like this all the time. You roll up on scene. You're an excellent provider. You immediately check a finger stick, and it's 25. Glucose is 25. Boom. Okay, you know what's going on. You get rapid IV access. You give them a bolus of a D50 or whatever you have, IV. Boom. A few minutes later, patient's back to normal. Feels totally fine. Hey guys, thanks. I don't want to go to the hospital. Okay, what do we do now? Okay, well, there is a specific protocol for this. It is the Diabetic Treat and Release Protocol. And what I have here is all of the things that the patient needs to meet to be allowed to just release this patient. All right, number one, they have to have capacity, right? Same game as before, okay? So this is just like, you can think of it just like any other refusal in a way, okay? In that the patient has to have capacity, and they have to be able to meet all of those things that we talked about before, okay? Now, sometimes people will nerd out about this a bit, because a lot of times what ends up happening on these diabetic treat and releases is that people treat them like a refusal, and they end up getting a signature on the refusal paperwork. Technically, this protocol is actually saying it's just okay to let this patient go. It's technically not a refusal, but that's a bit of semantics. That's just a bit of nerding out. I think a lot of EMS agencies just kind of still get them to sign the refusal paperwork and everything like that. And I think that's fine. I don't think it really matters that much. But just keep in mind that this is actually a little bit different. And especially because to justify it based on these grounds, it's actually even above and beyond the refusal. It's not just, oh, the patient has capacity, and so therefore we're going to let them refuse. We're actually protocolizing exactly what we need to assess to say, truly, this patient does not need more medical care. There's nothing that's going to happen in the emergency department. There's just literally no reason to transport this patient. That's what the rest of the protocol says. So for that to be the case, the patient has to have a clear etiology of their hypoglycemia. If you can't figure out why they went hypoglycemic, that's not a good sign, right? So the classic example would be, oh yeah, I gave myself, a big shot of insulin, but I ended up not eating breakfast or something like that. That's why I went hypoglycemic. That's a pretty clear example of, an etiology for their hypoglycemia. So they have to have a clear reason why they became hypoglycemic. Similarly, that reason needs to be pretty simple. It can't be something bad, right? So if they went hypoglycemic because they obviously have been on an alcohol bender for days and days and days, that's not cool, right? Or if they're febrile and potentially septic, and that's why they went hypoglycemic, right? That's not okay. So not only do they have to have a very clear, kind of obvious reason for their hypoglycemia, but it needs to not be due to some other illness that's going to harm them, right? It needs to be simple. Usually, again, the patient gave themselves insulin and didn't eat or something like that, okay? They need to not be on oral diabetic meds, and especially you really want to make sure it wasn't the oral diabetic meds that caused the hypoglycemia. Now, it depends on what class of medication they're on. Some can cause hypoglycemia, some don't, okay? But if it is an oral med that caused them to go hypoglycemic, that may stick around for a long period of time. It is not okay to just release them. If it's an oral med, you gotta go. So again, we're generally talking about sub-Q administration of insulin, okay? They need to have come back to normal in less than 10 minutes. I think most of you who've experienced this know it's probably even less than that. I mean, once you give that patient who's hypoglycemic, that D50 or maybe the oral glucose, they come back pretty quickly. If it takes them longer than 10 minutes, that's a concern that maybe there's something else going on. Don't let them refuse, okay? We gotta go, okay? They need to have normal vital signs, okay? Which they are actually very spelled out in the protocol. Glucose greater than 100, so you need to recheck it, right? Prove that their glucose is back up. heart rate needs to be greater than 60, systolic blood pressure needs to be greater than 100. That's straight out of the protocol. But basically what I'm telling you is they need to have normal vital signs, right? Which would also be an indication that there isn't some other illness going on, right? And then finally, there needs to be some sort of responsible person present, in addition to the patient, generally speaking. Is somebody going to be with them, watch them, something like that, right? Because if this patient becomes hypoglycemic again, and if they're by themselves, they may not have the wherewithal to be able to call 911 back, right? So we really need somebody else there to take care of them, and specifically, you should instruct that person what to do. Hey, stay with the patient, for the next couple of hours. Here are the signs and symptoms of hypoglycemia. If that happens, call 911. If it's appropriate, maybe give them a little meal. Maybe recheck their sugar in another hour, whatever. But give them good, reasonable steps about what to do next and when to call 911 back. Okay. So with that, if they meet all of those criteria, then you can actually let them, per protocol, stop providing medical care and leave them there in the care of that responsible person. That's okay. So that is it. That is the end of the talk. I hope this was helpful. Again, these are all the various reasons when you can stop delivering medical care. I hope you noticed that there's a lot of difficulty here. There's a lot of subtle things that are in there that you want to pay attention to, when you're thinking about stopping medical care. So, and when in doubt, whenever you are in doubt, then just provide medical care, right? Just provide medical care if you don't know what else to do. So anyway, it was my pleasure talking to you. I hope it was useful. Again, I'm Justin Benoit from the University of Cincinnati, and I'm sure I will see you on the street soon. Be safe. Thank you. Take care.